audio lecture. So in part one, we looked at the brain and the spinal cord, and now today we're going to kind of look at, we also looked at all the cranial nerves and everything, and then today we're going to look at all the nerves that kind of come off the spinal cord and go to the rest of the body, and then we're going to finish up the peripheral nervous stuff with just looking at kind of how our reflexes work and sort of what they're kind of made up of. Okay, so when you look at the branches off of the spinal cord, you're really looking at all the nerves that are going to a lot of our upper extremities and kind of the lower extremities. So you want to kind of take a look at this picture, and again, I can see all these little branches coming off the spinal cord, and I can see that they're kind of working their way kind of down into the arm, and I can also kind of see, we're going to see this picture a little bit closer here in a second, but I can see that some of these nerves are going to go to the back part of my arm, and all the musculature and all the skin and everything on the back part, and then I'm going to have some other nerves that are going to kind of come onto that anterior or that front part, and we just want to be aware sort of where each one of these is kind of going into kind of which part of the arm or which part of the hand they're going to feed into, because again, I can, if I have an injury or I have numbness and tingling, or if I have weakness in my hands or my arms, I can sort of trace it back to, okay, where is this nerve originating from? And sort of sometimes I can come up with, the pathway of that nerve will sort of tell me where some of the issues might be. Okay, so this is just a zoomed in look of the last picture here, and I see that I get these little trunks, and I can see that they're coming out from in between those spaces, in between my vertebrae, right? So I have my cervical spine, I have my thoracic spine, I have my vertebrae stacked on top, and I have my little discs, and we want to remember that I have these little openings in between the vertebrae where these nerves kind of get to sort of branch out of, okay? And I'm going to have these trunks, and again, certain parts of my cervical nerves are going to go to certain parts of my arm, and I can see that I end up with these little cords, and I get a lateral, a posterior, and a medial cord, and again, they're going to kind of tell you which part of the arm they're going to kind of feed into, okay? And there's three main branches, or three main nerves that I want you to sort of be aware of, okay? And it's going to be this kind of little radial nerve here. I'm going to also have a median nerve, and I'm going to have an ulnar nerve, and then I just get this little axillary nerve up at the top that kind of goes to that back part of my shoulder for me, okay? And this kind of tells you, the picture is going to tell you sort of where the nerves are kind of going to. And again, this person would be standing in kind of anatomical position where their palm is going to be facing forward. Okay, and the good part about these ones is that they're going to follow the bone that they're kind of named after. So this radial nerve is going to follow that radius, right? And then that ulnar nerve is going to follow that ulna, and then that median nerve is going to come right down the center, and then the axillary nerve is nice because we learned that in our terminology, and we know that that kind of means armpit, right? So the name again kind of tells you where it's going to. All you have to remember is that the radial nerve is going to be the one that's a little more posterior, and then the median and the ulnar nerve are going to be the ones that are going to go to that anterior or that front part of the arm. Okay, so here's a zoomed in picture again, and I get my little colors to tell me where things are going. But here is my axillary nerve, sort of behind the humerus here. Radial nerve behind the humerus, and then I can see my median and my ulnar nerve are going to be towards that front part. Okay. And then when we get down to the hand, because this is where it becomes a little more important, and I get a lot of people that come in with like numbness and tingling into their fingers, and a lot of it is sort of, again, tracing it back to, okay, which fingers are numb, which fingers are weak, which nerves are we kind of working on. And what you want to remember is that, if someone comes in and it's their whole hand that's numb, or their whole arm, the only place that all these nerves are together is really up high, okay? So that's a key indicator that, hey, it's probably coming from their neck, or it's probably these nerves getting entrapped as they kind of go through the shoulder. So you want to kind of know the pathway, because that kind of tells you, okay, where might these nerves be being interrupted, and where might they be being compressed upon. That's going to give these signals or these kind of symptoms. And then when I get down into the hand, I have certain nerves. You can see right here, I have this ulnar nerve, and I can follow it, and I can see that it's really only going to that pinky ring, a little bit into that kind of middle finger, and then I have my median nerve that's going to run and do my thumb and my index finger, and again that middle finger. So I can again kind of know, just based on where their symptoms are, where these nerves might be sort of being infringed upon, and then we can kind of work on those areas and see if it can kind of get improved. Okay, so for labeling wise, we just want to really be able to label ulnar nerve, median nerve, and radial nerve. Okay. And then this is kind of why it's important, and we mentioned the median nerve here, but one of the things that people are going to run into, especially now with all these kids are kind of playing these video games from when they're really, really young, and what's going to happen is that all these carpal tunnel and these overuse syndromes are going to get really, really more common, and they're going to start to occur really, really early. So a lot of these overuse injuries, it wasn't until you start working when you were in your 20s or 30s where these things would start to be a problem. But because these kids are on the video games and they're using their fingers all the time, and we're on the computer so much, they're going to just start to get more and more common even when people are a little bit younger. So what you want to look at here is here's my median nerve. And again, it has to kind of get through all these things. And again, I'm trying to put all my tendons from my fingers kind of into my hand also. And then I have this little band here that kind of holds everything down against my wrist. And it's just a narrow little opening, okay? So if you put your fingers kind of on the front part of your wrist and you just move your fingers, you're going to feel all these tendons kind of sliding and moving. And then you have to remember that that median nerve's got to get through there too. So as I move my fingers a lot and I hold tools or I'm on the computer, what's going to happen is as those tendons rub against each other, they're going to start to create some inflammation and some scar tissue. And what happens is it just starts taking up all the space in here, and then eventually it starts compressing this nerve. And again, one of the things for carpal tunnel, their pinky finger is going to be fine, okay? And it's going to be just mostly the thumb, the index finger, and that middle finger are going to be the ones that are going to kind of be affected. So it kind of tells you, like when people talk about carpal tunnel, sometimes they're talking about the back part of their hand or their whole hand. But really, if it's your whole hand, it's not technically carpal tunnel. It's going to be something else because, again, now it's involving, all my nerves. And what happens with the ulnar nerve is that it's going to branch off before it gets to this little ligament here, and then it's going to go. So, coming through this little tunnel here, it doesn't actually come through the tunnel, which means that this part of the hand is going to be fine in carpal tunnel, okay? But really, really common, and again, it's one of those things that you want to, if you get any numbness or tingling or neurological symptoms, it's one of those things, especially based on what your job is, that you want to get really fixed and kind of taken care of as soon as possible, because as it kind of lingers, it just gets harder and harder to kind of get it under control. And then here's what they do if it gets really, really bad and you can't kind of fix it with physical therapy or chiropractic or acupuncture, is that they're going to go in and they're going to try to cut that band here and kind of just open up that space for that nerve to kind of get into your hand, kind of interrupt it. But the other bad thing about nerves is that they heal really, really slow. So even after you fix it and you take all that stress off, it can really take up to a year, 18 months for things to kind of get back to normal. And most people, one of the first things they'll find, if it's not the numbness and the tingling, is that they'll start to notice that they just start dropping things all the time. So they drop their keys, they drop things, and that's, again, going to be one of those first things that you're going to notice where you just don't have that feeling in your fingers as much. So you start to sort of feel like you don't have as good a grip on things. Okay, so now we get to the lower limb. And again, we're mainly looking at two main nerves, one that goes to the back and one that goes to the front. And in this one, again, I get all these branches coming out of my lumbar spine and my lower back. And what you're going to find here is I get what they call these little plexuses, okay? Or you'll hear them called branches. You'll hear a bunch of terms. But the plexus, it just means that this is where the nerves are originating, or the part of the spine that they're originating from. And what you find is the nerves coming from the upper part of my low back, okay, are going to go towards the front part of my leg. And then we'll see the nerves that come from that low back are going to go down the back of my leg, okay? And this one kind of follows the arteries, the main arteries and things like that too. And again, the name of the bone that it follows kind of gives this one its name too. So we get this femoral nerve, okay? And that's going to be the main one that does the front part of my leg. And you can see it kind of branches off to the front part of my lower leg too. But it's the main one, again, that goes to the front, okay? And what you hear most people talk about, we'll see the sciatic nerve in a second here, is they'll talk about sciatica, but they're two different nerves. The femoral nerve in the front, sciatic nerve in the back. The pain towards the front of my thigh is, again, coming from upper a little bit higher in my low back, and it's going to be because of this little femoral nerve, okay? And here's a look at the bottom parts. You can see with the numbers, these are branching off of my very low back, or my L4-5, and then getting into my sacrum. Okay, and again, this one's going to make my sciatic nerve, and it's going to, again, go back down the back part of my leg. Okay, so here's a picture, again, from the front, and I know it's the front because just by looking at the pelvis, and I can see the kneecap here. So again, you always want to orientate yourself and be like, hey, am I looking at the front or the back? Because then, hey, if you know, hey, I'm looking at the front part, then I know this is going to be that femoral nerve. It's not going to be that sciatic nerve, okay? So here's, again, just a zoomed in picture here of the front part, and I just get a better picture of this femoral nerve. And then I get another picture here where we're just kind of following our branches down into the lower leg. Okay, and now I start looking at the back. Okay, so now we can see that these nerves are going to come out a little lower. And again, I can't see the kneecap anymore. I can't see, I see the back of the heel. I see my sacrum a little bit better, so I know I'm looking at the back part. And again, this is my main nerve we want to be aware of. And then this is going to be that sciatic nerve. And you can see that it goes sciatic nerve, okay? Then it's going to be the tibial nerve because it's following the tibia. And then I'm going to also get this common fibular and then this deep fibular. So again, these ones are not too hard to remember because, again, if I know the fibular nerve is going to be more lateral because I know my fibula is lateral, and I know the tibial nerve is going to be right down the middle because that's just the pathway of my tibia. But this one for low back pain and pain in your butt, and sort of pain into that back part of your leg. Again, you want to remember that it's coming from that sciatic nerve. And we looked at the muscles last time, and we looked at all the rotators, and we saw that piriformis muscle. And again, the reason that's important is because it sits right over top of the sciatic nerve, and if it gets really, really tight, it can compress that nerve and give you that numbness and tingling kind of going into the back part of the leg. Okay, so here's just a zoomed in picture of this big, huge sciatic nerve. Okay, and then I can follow it down again. I can becomes tibial nerve, common fibular nerve, and then I also get this little deep fibular, where again I'm trying to get to all the muscles in my calf and that anterior sort of side part of my leg with that femoral nerve, and then again with this sciatic nerve. Okay, so that's how we branch it all together. And again, we want to focus on, for all the extremity stuff, we just want to focus on the main nerves. So radial nerve, ulnar nerve, median nerve, and then I want to know my femoral nerve, I want to know my sciatic nerve, I want to know my tibial, and then I want to know my common fibular, and maybe just that deep fibular. Okay, so now we get to the last part of our peripheral nervous system, and we start looking at these reflexes. Okay, and we did when you guys did the neural test, at the end we sort of talked about your patellar reflex, and everyone knows about that one where you kind of hit the knee and you're going to straighten your leg, or we talked about the Achilles reflex. And this is we just want to go over the different types of reflexes, and then we just want to look at, how exactly do our reflexes kind of work, because it's pretty cool. So many of our body's control systems are going to be set up as reflexes, or what they call these reflex arcs, okay? And what they enable is this rapid and predictable response. And this is, again, just about safety, okay? So we want to be able to kind of respond to dangerous things really, really quickly. And the main thing is that we don't want to have the brain take the time to interpret things. We want to just respond immediately so that we can prevent as much damage as possible, okay? But reflexes can be inborn or they can be learned. So these are my inborn or intrinsic reflexes. Okay, so they're rapid. They have predictable motor responses, so your body's going to respond with your muscles in the same way every time. They're going to be unlearned. They're going to be unpremeditated. They're, again, going to be involuntary. That's why if you whack that tendon on your knee, you're going to straighten your leg whether you kind of want to or not. They're built into your neural anatomy, and then again, I don't have to think about them. And these are all our responses to kind of maintaining our posture, pain, kind of organ activity, okay? So again, intrinsic, involuntary, your body kind of just does these naturally and kind of on its own. So these are the ones that we're probably most familiar with, right? So if I touch something hot, my body is going to pull my hand away from whatever is sort of hot or whatever I'm touching that's kind of burning me. So most common, this is like you touch the stove or the iron, or you touch something, and again, you're going to fire this bicep to flex your arm because that's going to pull your hand away, okay? Or the other one that's really, really common is if I step on like a nail or I step on something sharp, you're going to pick your leg up, right? So you're going to fire muscles that are going to raise your knee up. You're going to fire muscles that are going to kind of bend your knee because, again, they're trying to get that foot off of whatever you stepped on and sort of prevent any more damage from kind of happening. And again, this happens, you pick your foot up before you even realize that you've stepped on a nail or you've stepped on a pin, or one time I stepped on a toothpick that my kids have kind of left on the ground, and that was probably one of the most painful things that ever happened to me. But again, you're gonna pick that foot up really, really fast, and then you'll have time to kind of process and be like, okay, what did I step on? Okay, and then we also have these learned reflexes, and these are going to be a little different because they're going to result from practice, right? Or it's just this repetition, and can be for the things we're going to talk about, but it can also be for sports and things like that where you're just going to practice something so much that you don't even have to really think about it anymore. But the two most common kind of experiments are going to be this Pavlov's dogs that you've probably heard about, and then we have this little Albert experiment, and these are going to be more our association. We start to associate things with other kind of sounds and things that we kind of experience. So here is the classical conditioning or Pavlovian conditioning. And this little cartoon kind of sums it up, right? Where you ring the bell and the dog doesn't really know what's happening, right? But if you give the dog some food, they're going to start to salivate because saliva is going to help them break down their food. So as soon as they see food or they smell food, they're going to start to salivate because their body wants to start kind of breaking this down. So what they did in the experiment is that they would ring the bell and then they would give the dog some food and the dog would start to salivate, okay? But after you do this enough times and the dog starts to associate the bell with the food, you can just ring the bell and the dog will start to kind of salivate, right? Which is not what happened at the beginning, right? They rang the bell, nothing happened because the dog did not, again, associate the bell with the food. Okay, so this was what they would call this classical conditioning. The next one that, again, if you've taken any psychology classes, they always go over this one, is that what they did was they kind of taught this little baby here to associate the white rat with a loud clanging kind of noise, right? So they would kind of let him play with the rat initially. He wasn't afraid of the rat, but then what they would do is every time the rat came in, they would sort of make this really loud noise. And then what happens is that the baby, every time he sees the rat, he's going to be afraid, right? He starts to be afraid of anything that's kind of white and furry. This is also one of those ones that they would never really allow you to do anymore because, again, they don't want to create any sort of long-term problems or anything like that with any sort of little kids. So this is one that they did a really, really long time ago. But again, it's associating something that's not normally scary with something that you've sort of created this where they're going to be afraid, okay? So here are the 5 components, and again, I just want to know the 5 components of the arc because this is a good, again, multiple choice question, and I just want to know sort of what each one of the functions are, and a lot of these we already know because we've kind of gone through them a little bit already, okay? So we have a receptor, and this is going to be the site of the stimulus action, right? So that could be pain, it could be a bunch of different things. We have the sensory neuron that's going to transmit, right, whatever the receptor senses to the central nervous system. We have our integration center. This is where it kind of changes because it's not going to be the brain with the reflexes, okay? It's just going to go to this interneuron or it's going to go to the spinal cord. And this is where people kind of make the mistake all the time because a lot of times in the question, they'll ask you like, hey, do reflexes go to the central nervous system? And most people are like, hey, well, it doesn't go to the brain, so it does not go to the central nervous system. But it actually does go to the central nervous system because, again, the spine is considered part of that central nervous system, okay? So this is just where you kind of get tricked or don't quite understand exactly what they're kind of asking you, and we'll see the picture here in a second too. But we have this little interneuron, and it's going to be the synapse between my sensory stuff and the motor or the firing of those kind of muscles or the firing or the the working of those effectors. Okay, so now we have the motor neuron. So this is going to conduct my efferent impulses. And again, it's the integration center to the effector organ. And then I have my effector, which is, again, a muscle fiber, or it can be a gland cell. We've gone over the effectors a bunch of times, but it can, tell that effector to contract. It can tell it to secrete something. It can tell it to kind of do its job here. So here is our picture here. And again, this is my effector is my muscle, my receptor, right? And then I have my sensory neuron, right, going towards the spinal cord. I have my interneuron, and then I have my motor neuron that goes out to the muscle, okay? But again, it does not go up to the brain for interpretation. It just goes receptor, spinal cord, out to the muscle, makes this fast response where we can, again, keep ourselves as healthy as possible and make it where we're, our body is in danger and we're producing the least amount of damage that we possibly can. So now we get a classification of reflexes. Again, we go back to, terminology stuff, and we know that soma is, again, body. Okay, so these are somatic reflexes. They're going to activate our skeletal muscles. And then we have our autonomic reflexes, which are going to activate our visceral effectors, or our glands, smooth muscle, cardiac muscle, all the things that we're not really in control of. Okay. So now we look at a couple just specific instances. So we have these stretch and tendon reflexes. We've talked about a few of them before, but they're going to require 2 types of information provided by these proprioceptors. And what they're going to monitor, okay, so these are our receptors that are going to monitor specific things, and we're going to have one that's going to monitor the length of a muscle, and that's going to be our muscle spindles, okay? And then we have another one that's going to monitor the tension in a muscle, and it's going to be monitored by these tendon organs, okay? So these are just specific types of proprioceptors that are, again, monitoring what length is my muscle, how much tension is my muscle sort of absorbing at this particular time. All right, so again, these are easy to remember because you go spindle has that L in there, so it's going to monitor muscle length, and then we have tendons has a T, and they're going to monitor tension. Okay, and then here is probably the best example, and we've kind of looked at this with the patellar reflex. So you're sitting, your leg is hanging off the table, it's bent to 90 degrees. You kind of whack this tendon here. What that does is it puts a really quick stretch into that quadricep muscle, okay? And what's going to happen is in an effort to kind of decrease the stretch, okay, that the muscle is absorbing, my body is going to contract that muscle, or it's going to contract it in an effort to kind of shorten it, right? So if I shorten it, it won't be stretched out so much. And this is kind of exactly what happens, right? I hit that tendon, I feel that stretch in there. My body contracts my quadricep in an effort to shorten that muscle that's being stretched out, and it puts it into this short position, takes that tension off, and then my body can kind of relax. Okay, so in this stretch reflex, the muscle that is being stretched is going to contract, And the opposing muscle, which is why they're showing this hamstring here, it's actually going to relax because, I don't want any interference from the hamstring when I'm trying to protect this little quadricep here. Okay, so that is kind of the best example of just these, these are probably the most common ones in the body are these stretch reflexes, but important to remember that, the muscle that's stretched is actually going to contract in an effort to shorten it, decrease that stretch, and then my opposing muscle is actually going to relax so that it can, I can shorten that muscle that's being stretched as quickly as possible. Okay, so that's it for the peripheral nervous system. We only have one more thing that we have to kind of cover for the systems, and we have to do the autonomic nervous system, which is really, really short, and then we're going to move on to our special senses.